Hello, everyone. Welcome to the international webinar on behalf of Department of Faculty Development and Internationalization at Lahore College for Women University, Pakistan. The title of this webinar is Impact of the Pandemic on Informal Caregivers of People with Dementia globally and in South Asia. I am Dr. Saima Iman, the host for today's event. I'm Assistant Professor at Department of Applied Psychology, LCWU. I'm grateful to you for sparing us some of your precious time to attend this international webinar. Now I will introduce you to the guest speakers. We have our Honorable Vice Chancellor, Professor Dr. Bushra Mirza, as a chief guest for this event. Dr. Bushra Mirza did her PhD from University of Cambridge, UK, and postdoc from University of North Carolina, USA, in the field of plant molecular biology. She has been awarded Best Young Research Scholar Award by Higher Education Commission in 2009 and a gold medal by Pakistan Academy of Sciences in 2008. In addition to her many awards and honors, she has made LCWU a progressive university and she's playing a vital role in women empowerment. I welcome the guest speakers from Ireland and France to Lahore College for Women University, which is the largest women university in Pakistan. As our main guest speakers, we have Dr. Irasima Leroy, who undertook her basic medical and psychiatric training at the University of British Columbia, Canada, followed by a fellowship in the neuropsychiatry of neurodegenerative disorders at the Johns Hopkins School of Medicine. She joined the faculty at Hopkins before moving to the UK in 2002. She undertook her doctorate before taking up the post of Professor of Psychiatry in Aging and Dementia at the University of Manchester. She is now Associate Professor, Geriatric Psychiatry at the Global Brain Health Institute, Trinity College Dublin. She's the lead of an EU-wide Horizon 2020 research program on sensory cognitive health in dementia. She's the lead of the recently funded HRB Clinical Trials Network, Dementia Trials Ireland. We also have two discussants. The first discussant is Dr. Yawa Chen, who received her medical school training from the University of Lyon, France, followed by residency training in neurology at the University of Lille, France. She also earned master's degrees in biology and health and completed a fellowship in the Memory Clinic of Lille. She simultaneously obtained a PhD position in a translational work of a murine model and a cohort of patients with Alzheimer's disease in a laboratory of vascular and neurodegenerative diseases. She worked as an Atlantic Fellow in the Global Brain Health Institute in Trinity College Dublin from 2019 to 2020 and as a Research Fellow for the Trinity Center of Aging and Intellectual Disabilities until 2021. She continues to work in the Memory Clinic as a neurogeriatrician at the University Hospital of Lille in France. She is now Associate Professor in Geriatric at the University of Lille. She is the coordinator of the CLIC Caregiver Study. The second discussant is Ms. Anna Jin, who obtained her credential as a sustainability engineer from Tung Hai University, Taiwan, where she worked as a clinical researcher and a teaching assistant. In Taiwan, she also worked as a human resource coordinator and a language specialist in which she first interacted with the migrant population in the country. After publishing several scientific papers about migrant caregivers in Taiwan, she undertook a master's degree in global health from Trinity College Dublin to continue researching and advocating for the caregiver population. She is now working as a healthcare coordinator in Uniphar Group, one of the biggest pharmaceutical companies in Ireland, while acting as a South Asia Regional Research Officer for the Coping with Isolation and Loneliness During COVID-19 CLIC project in collaboration with Global Brain Health Institute. Now I invite our Honorable Vice Chancellor, Professor Dr. Bushra Mirza, to please say a few words.
Bismillahirrahmanirrahim. Assalamu alaikum, and a very good evening and probably morning for some of your speakers. It's a really honor and pleasure for me to inaugurate this seminar because I feel it's such an important topic of talking about caregiver in this pandemic because I feel that pandemic has affected not just the patients, but the people who are supposed to take care of the patients as well. Everyone has been affected. And we are continuously in that state that yet we really do not know when would be in the previous situation or the normal circumstances before the pandemic state. But I'm so honored that our psychology department, Saima Iman, who herself is a very brilliant researcher and academician, has organized this webinar, as well as I'm grateful to Director DFDI, who has been continuously organizing such events for our young researchers and students. And I'm so very impressed by the resource person and speaker you have gathered. I'm so grateful to Professor Leroy, Miss Anna, and Dr. Chen. I see that they have such an extensive experience and qualification in their field. I'm sure their presence and their contribution would be very helpful for our researchers as well as young faculty members. I feel particularly the topic of dementia is something which the problem we find in every part of the world, in fact. And when I looked at this seminar, it's kind of personal also, because I think every one of us has experienced some family members who have some sort of mental problem at certain stage of their life, particularly at the older age. Both of my parents were actually Parkinson patient, and I experienced that trauma which you have to go through as family to see such your loved ones in that state, and you feel so helpless and depressed that it's true that the family members and caregivers also need so much psychological help to while going through that stage. So I'm hopeful that this seminar would be very productive for not just for the research and academic purpose, but also for being helpful around such people who need that help. So thank you very much, Saima, for organizing this seminar, and I wish you all very best of luck. Thank you.
Thank you, madam, for your time from your busy schedule. We are really happy to have you. Now I invite Dr. Irasima Leroy to begin with her talk, with her discussants. Thank you.
Thank you very much for that very gracious introduction. Thank you to Professor Mirza for the very lovely introduction, and for organizing it, Dr. Saima, and also to the director, and wonderful organization. So I hope we will be able to give you some interesting information over the next little while. And just a bit of a warning, we're going to try to interact with people a little bit. So make sure that you're all bright and awake in case we spring on you and ask you to answer a question. So I'm going to start by sharing my slides. Just let me get this out of the way here. Sorry. Okay, all right. Super. Okay, so as you've heard, we're going to be talking about the impact of the COVID-19 pandemic on informal caregivers, with a particular focus on care burden, loneliness, and social isolation. Now, this is called the CLICK study. It's a global study, but we have a large sample of respondents from South Asia. And so what we'll do is start off with myself presenting some general information about care burden, loneliness, and social isolation. I'll then switch to my colleague Yao, who will talk about our global findings from the study. And then Anna will come in at the end, and she'll talk about the South Asia findings. So I hope you'll find it interesting. So this is a quote that I've used before, which I find really very poignant. It's from Eleanor Roosevelt. There are only 4 kinds of people in this world: those who have been caregivers, those who currently are caregivers, those who will be carers, and those who will need caregivers. So if we think about our own experience, I think we can all say we fall into one, if not more, of those categories. So this is a topic that touches on every single one of us. You'll all be very familiar with the roles of a caregiver for a person living with a long-term or even an acute condition, physical or mental health wise. This can involve personal care, administering and monitoring medication, disease management, attending appointments, and so much more. But the aspects that we'll be focusing on will be a little bit more on the social scale. For example, touching on the social network, thinking about social isolation, interpersonal relationships, namely loneliness, and so on. Now, we all know that the impact of care provision for people with brain health challenges specifically can be very challenging. And there's this notion of what we call the hidden or the invisible patients. And that's not the person with the brain health challenge. This is the person, the care partner, who themselves can become a patient in need of care and support because of what they're experiencing. Now, this is, of course, quite a negative view of caregiving. And it's very important to keep in mind that the narrative around caregiving in these contexts is starting to change. And there's an increased focus on resilience, the dyadic relationship, the positive aspects of caring, and so on. However, for the purpose of the pandemic and our discussions here, we will be focusing a little bit more on the negative side, if you will, namely the burden. And you can see from my bullet points here, care provision for people with brain health challenges can be physically demanding and mentally exhausting. It can be associated with negative feelings, stress and burden, decreased quality of life, worsening physical health, worsening mental health, and decreased socializing and loneliness. When we refer to brain health challenges, that's a very broad term, but for the purposes of our study and what we've been looking at here, this refers to people living with dementia as the care recipients. It refers to people with enduring mental ill health, like, for example, schizophrenia, depression, bipolar disorder. And it also refers to people with intellectual disability, although at times in the analysis we've kept that group apart. So, loneliness and social isolation in people with dementia and their care partners. What was the situation before the pandemic? The pandemic didn't invent these issues. It simply exacerbated them. So let's just touch briefly on those concepts to make sure that people are very clear in their minds what these concepts and these constructs refer to. Loneliness is a subjective sense of inadequate quantity or quality of social contact and longing for close and emotional relationships with others. Social isolation, on the other hand, is an objective and quantifiable lack or reduction of the social network size and social contacts. So in other words, you can not have social isolation, you can be very socially connected but still be lonely, or you can feel very lonely but still have a lot of socialization, or vice versa. So there's various aspects to this, and it's important that we tease it apart in order to understand the constructs better. The impact of loneliness can be on the individual. For example, loneliness and social isolation are risk factors in older people for cognitive decline, for increasing risk of dementia, greater physical mobility, and higher mortality rates. And there's good data to support all of these. But there can also be the impact of loneliness on society more widely. And particularly what we see here through the pandemic is that both positive and particularly negative emotional states, like worry, fear, loneliness, of individuals can spread rapidly through communities through this idea of emotional contagion. So, thinking about the impact of the pandemic on caregivers, we can think about intrinsic factors and extrinsic factors. The extrinsic factors, of course, are things like the support systems, were they there or were they taken away and closed up? Thinking about the pathways for patients and the kind of supports that are extrinsic to the dyad of the person living at home with their care partner. The intrinsic factors refer to loneliness, social isolation, type and severity of symptoms or clinical presentation or lived experience of the person with the brain health challenge. And these are the different aspects that are important to examine. So I'll briefly introduce you to the CLICK study. This was a cross-sectional, online, pragmatic global survey. And many of you will have likely also conducted these kinds of surveys during the pandemic because there was a desperate need for information, for data, for understanding what the lived experience was in this crazy world that we've just been through. This survey involved adults over the age of 18 who had the capacity to consent to research, and it took place between June and November of 2020. So think about at that time in the context of the pandemic, we were still relatively early on. We were starting to get the feel that this wasn't going away anytime soon, and the negative impacts were really starting to manifest. This involved self-administered questionnaire, and we were able to reach over 20,000 adults around the world from 100 countries. And the overall aim of the survey was really to pin down and understand the psychological impact of the pandemic through validated measures of loneliness and social isolation. Now, there have been a number of surveys done looking at loneliness and social isolation, but this is the only survey, as far as we know, that has a global reach and that used validated measures of both of these constructs. So this is what we call the online parent survey. It took about 15 minutes to complete. It was self-administered, and it used these particular scales, and it had 129 questions in total. Sounds like quite a big burden on the respondent, but in fact, we had a very good response rate with very little missing data. Now, within that parent survey of 20,000 respondents, we had the ClickCarer Survey. This was a sub-study. Every respondent was asked the question, do you provide care and support to a family member or a friend with a long-term or life-limiting health problem or disability, including a mental health concern? If the question was yes, that would open up a series of other questions specifically related to caregiving. We asked about caregiver characteristics, including the nature of the relationship with the care recipient. Particularly, we also looked at the place of care provision. In other words, were they cohabitating with the person they were providing care for, or were they supporting somebody in their own home, or were they supporting somebody, in other words, in the care recipient's home, or in some kind of institution? What's very common here in Europe, for example, is if a family member is in a care home, then the family member will then go and visit the person on a daily basis and help with meals and visits. And of course, all of that shut down during the pandemic. And we were very interested in finding out how the role of the informal carer changed as a result of the pandemic. We then looked at caregiver burden, taking a single key question from the Zarek Burden interview, which the evidence suggests is one of the all-encapsulating questions. And we looked at how the care changed from before to during the pandemic. We also asked questions from loneliness using the modified 5-item UCLA loneliness scale. We then split up emotional and social loneliness because it was very interesting to kind of look at these domains or constructs separately. So emotional loneliness is this sense of emptiness, an internal subjective sense of emptiness. Whereas social loneliness has a sense of how many people are there that I can trust completely. And again, we asked this before and during the pandemic. And these constructs can be pulled out of one of the validated loneliness scales. And finally, we explored social isolation using a very well validated scale, the 6-item Lubin social network scale. And the reason we were able to include these scales in our research was because our initial parent panel involved a network of loneliness researchers from around the world, including the authors of these scales. And they were very keen for them to be rolled out and for us to investigate this issue during the pandemic. So I'm now going to switch over. And after a brief introduction, I'm going to give the floor to my colleague, Dr. Chen, to talk about what our findings were from the global view. But before I do that, I just want to take one of the answers from our free text items from the questionnaire and share it with you to give you a flavor of the types of experiences people were reporting. So this is the report from one individual. When I got sick in early March and had to go to the hospital, my partner had to go to a nursing home as she required 24/7 care. When I came home a month later, of course, she wasn't there. She remained in care. In addition to losing her presence in our home, at the same time, I lost visiting privileges with her. So here you had a person who was already themselves unwell, forced to put their family member into care, and then couldn't even visit them in care. All contact had to be cut off. So the care homes became isolated islands. I also lost in-person visits with friends, attending church, going safely to public places, and participation in my regular activities. Now, this is only one example of the many hundreds of responses we got, but I think it really paints a very important and typical picture. So in that context, I'm going to hand over to Dr. Chen, and she's going to put you to work. So she's going to ask you all a question. I'll hand over to her and she can explain.
Thank you, Ira. So thank you for the presentation of the background and also the presentation of the clinical case. We have actually plenty of these very painful testimonies from the open question. You should see on your screen, well, if you are joining us from Facebook, I don't think so, but if you are joining us from Zoom, you should all see on your screen a poll question. I think there is only one or two, but let's start with the first one. So what are the risk factors, according to you, associated with higher care burden? Is that if a caregiver is at older age, if the caregiver is a man, or if he is or she is married, or if the caregiver care for someone living with dementia? If the caregiver care for someone living at a different place as the care recipient, if the caregiver experience higher social isolation, just as Professor Leroy presented you earlier, or if the caregiver experienced higher loneliness, or if it is related to interruption of usual services, or if it's related to poor mental health, and the last option is poor physical health. So I don't know if you can see the question on your Zoom screen. Maybe, Ira, you can tell me.
Sorry, I didn't realize I had to pull it down. Sorry about that. Okay, there we go. Okay. Yeah, you can answer more than one question. Is that right?
You can answer, this are multiple, so you can tick all the answers that apply. What I don't know is I don't know if the second question from Anna is displayed or not, but please focus on the first question now and answer to the first one. Saima, do you think people in Facebook, if they are looking at us from Facebook, I don't think they will be able to answer to the poll, no?
Yes, I think not from the Facebook, but how to click these answers, because the whole box is being clicked.
If you click on all the boxes, that means you think all the factors are associated with a higher burden.
Yes, but I'm unable to click because the boxes are not appearing with the options.
Oh.
Okay, so it looks like Zoom polling has failed us. Okay, so we'll just have people think about the questions and then, Yao, you can give us the answers.
Yeah, sure. So the question was, what are the risk factors, according to you, that are associated with higher care burden? And actually, some people will think that older age is a risk factor, but it is not. Being older, it makes you also a little bit wiser or more resilient, and it was not associated with higher care burden. Being a woman was a risk factor. Caring for someone living with dementia, if you are highly lonely, and if you are experiencing poorer mental health. And of course, if the usual services were interrupted. But don't worry, because I will present you the data now, so we can come back to this. So next slide, please. Yeah, so Ira presents you the Click overall survey. And in this big sample, about a quarter of them identified themselves as caregivers because they said yes to the question. So that will be more than 5,000 people all around the world, because the survey was translated into 10 different languages, including Urdu, Bengali, and we actually got answers from 59 countries. So we have a quite good representativity of different countries in different continents. And Anna will present you a little bit later the data, especially in South Asia. But you can see here 10% of our caregivers came from South Asia. In our sample, so the global caregiver sample, most of the respondents were women, so representing 80% of the respondents. And when you look at the age categories, most caregivers were in their middle life. And I don't put here, but the care recipient condition were oftentimes dementia or mental health issues. So basically brain health challenges. And caregivers usually provide care at the same place as their care recipients. So they live at the same place. And also there will be mostly one family member, so spouse or the children, rather than the friend or neighbors. So that will be the global demographic characteristics of our caregivers in the global sample. And we want to ask two main research questions. The first one is, which caregiver groups have had the most difficulties coping with an increased subjective care burden? And the second one, was the subjective care burdens increase associated with the discrepancy between social loneliness, social isolation, and the loneliness? So to answer to the first research question, we use a statistic model that we can call a nested logic model. I don't know if you are all familiar with that, but I learned from this study. Actually, it is kind of Russian doors. So you will want to analyze the associated factors without any preconceived ideas, and you will just put one model up to another one, and then look at the final model, the factors that remain significant at the end. So we have some ideas. So we separated the different variables that we have from the survey into 4 different categories, which will be the individual caregivers' characteristics, the social demographic one, their health status, the care diet's characteristics. So I talk about the recipient's chronic condition, the relationship they have with their care recipient, and the place of care, the COVID-19 disruption, and at the end, the changes in social connectedness. So here will be the results from the first model. Actually, age. So having, if you are young, if the caregiver was younger, it will be associated significantly to a higher burden. If the caregiver was a woman, if the caregiver was married, which will be the risk factor, and if the caregiver have a poor financial situation. Whereas the education level, having children, the employment situation, and the financial situation, especially during COVID, were not significantly associated with higher burden. And that is the interesting part. When you add the second Russian door, so which will be the, we stay with the first one, next slide, Ira, because in the first model, we have actually a little bit more variables. So the general physical health and the general mental health during COVID were also associated to a higher burden. And the location where caregivers lived and the general mental health and the pre-existing health condition were not significantly associated with the higher burden. Next slide. And now when you add, that is why I want to say what is interesting, because I told you earlier that we found the older age was not significantly associated with a higher burden. So here, when you add the second model, which was related to care diet characteristics, age became not significant anymore. And the caring for a person with physical disabilities, with dementia, with intellectual disabilities was significant. And if caregiver provide care at the same place as the care recipient, that will be a risk factor. Whereas the relationship, the type of relationship that the caregiver had with the care recipients were not significant. Next slide, please. Then we look at the third model all the previous variables remain significant, and if the caregiver had a diagnosis of COVID during this survey period, it would be a significant risk factor. If they had someone dead during this pandemic, or if the care abilities changed due to COVID, those are all the risk factors related to higher burden. And now I will present the last, final big door model. And you can see that the marital status, caring for someone with physical disabilities, became not significant anymore. So at the end, oh yes, and the social isolation was not a significant risk factor. So here, actually, at the left side of this slide, you have all the significant risk factors associated with a higher care burden. So the gender, the general financial poor financial situation, poor mental health, if you care for a person living with dementia or with intellectual disabilities, if you live actually at the same place as the care recipient, and if you had a diagnosis of COVID, and especially when your care abilities changed during COVID, and that will be our final results. Next slide. So here's basically the conclusion to our first research question that I just mentioned before. And now to answer to our second research question, which was the subjective care burdens increase associated with the discrepancy between social isolation and the loneliness? So actually the discrepancy between the two has already been described. And in this paper from 2016, they separated into 4 different profiles, and they described that from the Irish population and the UK population. The first 2 profiles will be the concordant high or low lonely people. So they will be highly social isolated, and it makes sense that they can also feel high loneliness. And the 2 last one were the profile that were discordant. So the first one, for example, which will be someone who is not so socially isolated, but they will still report high loneliness. And the second one is the robust profile. So that means people will be highly socially isolated, but they do not report a high loneliness. And we want to know, next slide, please, if these different profiles were related to higher burden. So in our sample, the most frequent profile was the concordant high lonely profile, which makes sense because during COVID, you will agree that most of people were socially isolated and they will feel lonely, and followed by the other profiles. Next slide, please. And when we look at the relationship between these 4 different profiles to the increased burden, where we have very interesting results, they were significant. I want you to focus your attention on the 3rd line, the profile of discordant susceptible people. So remind that those persons, they are not so socially isolated, but they will still report high loneliness. And here you can see that in this group, the prevalence of reporting more burden than usual is the highest when you compare to other profiles. And the robust profile, on the contrary, they will report the same burden as usual, as they were the most resilient people to the COVID-19 impact. Next slide, please. And we want to look if this association remains when we compare to the intensity of burden. So remember, Sima told you that we ask about if the burden was at different levels. And again, we obtain the similar results. You can see on the 3rd line that the profile of discordant susceptible people, again, will report very frequent or nearly all the time they will feel the burden. Next slide, please. So the conclusion to our second research question was that loneliness seems to be a stronger driver than social isolation for a higher burden from the caregivers, and especially for our discordant susceptible group. Thank you.
Super. Thank you very much, Yao, for those very interesting results. I'm going to switch now to the third part of our presentation, which is Anna, and she's going to hone down from the sample into the South Asian view. And she's going to try the quiz, but it may not work again, so beware. Okay, so first of all, I'm going to present a couple of cases from the open text qualitative aspect of the presentation that was specific to this group of South Asian respondents. So the first is a 42-year-old father of two taking care of his mother who lives with dementia and long-term physical condition. And he says, the dementia diseases are known to us, and due to corona, we were not able to provide proper treatment. Man can feel lonely due to mental pressure. And it's quite interesting because we had a male respondent here. So of course, much of the European respondents, the higher proportion were women. And the next respondent that we've picked is a 39-year-old single female caring for family members with mental health conditions, and she's self-reporting a poor mental health state. And what she says is as follows: I like to care for people. I like to stand beside vulnerable people. I try my best to help as much as possible. And this post is my family member. This is my responsibility. Loneliness means to keep distance from my family, neighbors, friends. Keep yourself away from everything. I am feeling lonely at the time of COVID-19. And that was her response. So talking us through these, Anna will give you some of the data that she's been analyzing. And I'll jump in here. I apologize for the typo. The Urdu is my typo. It's meant to read Urdu, so sorry about that. Anna, go ahead.
Thank you, Ira. Yeah, I don't think the pool is working anymore, so I'm just going to skip that. But can you move on to the next slide, please? So I'm just going to put this on the chat because I think it's too long for the pool. Oh, sorry. Yes, but this was the question that I was going to ask everyone, and if you can see it in the chat. So the question was like, who is more likely to be a caregiver in South Asia with a high level of burden? Is it a woman? We call her Anika, a 28-year-old woman with diploma, so she got to have some education, that's taking care of her parents and in-laws that suffer from physical disability and dementia. The lockdown has led to her being stuck in home with the family, or, yes, thank you very much, or it's B, you can still see it in the chat, Zubair, a 42 years old father of two with a postgraduate degree and a high-paying job that has not been able to visit his parents that suffer from dementia in the care facility. His mother would call him daily to ask why she was abandoned in the care facility. Or C, Anusha, a 68 years old grandmother without any prior education and a low socioeconomic status that is caring for her children that suffer from mental health condition and intellectual disability. The pandemic has encouraged her other children to come back home and help around the house. Or D, all of the above. So what, in your opinion, what kind of person, what kind of caregivers in Southeast Asia would have a higher level of burden among those people? Because I take all of this profiles from our respondents, and they are it's gone from our respondent. And in your opinion, which one will have a higher level of burden? Maybe absorb it a little bit, look around.
Is it Anika, 28 years old woman with a diploma taking care of her parents and in-laws, and due to lockdown, she's stuck at home with her family?
Okay, that could be. And why would you think so, Dr. Seema?
I think this option A.
Do you have any particular reason for that?
I think that usually women, they don't feel very comfortable with their in-laws, and that's why they might be experiencing a high level of caregiver burden in their family. So it's difficult to take care of in-laws. Maybe that is one of the reasons. It's just a wild guess. So
that's a very, very good guess. Can you take the PPT back here? Thank you so much. Oh, okay. That's a very good guess. But what I'm the pool keeps showing up. What's happening? Okay, but yeah, that's a very, very good answer. I'll reveal the question at the end. But before starting that, like I met Ira around last year during the pandemic, and okay, thank you. Can you move forward to that Google slide, please? There you go. So I met Ira last year during the pandemic, and when she talked about the Caregivers project, I did a very simple Google search, as anyone would do. And if you do this, you will find that in 0.08 second, because Google is super fast right now, you'll find 44,700 results in for the keywords of caregiver burden South Asia. And I was like, oh, okay, 44,000 is not that bad. But then I did another round with caregiver burden United States. And then as you can see over here, there, it's 2,800, or sorry, 289,000 results. So if you are very, very good at math, which I'm not, I use calculator, you will figure out that the data in the United States or Western country will be 5, 6, 7 times more than the one that we have in South Asia. And then one of the reasons we are doing the South Asian data analysis is that we want to set a baseline. So next time when a student or when a policymaker, when someone is trying to Google the exact same thing with what I did, they'll find data, but they'll find research that can base their policy and intervention and makes the population, the caregivers population, better. Can you change to the next slide, please? So the first thing that I have to do is that I have to build a team of writers, and I have to convince my co-author and my coworkers on why, what's unique about the aspect of caregivers in South Asia versus the European. And one of the most interesting to me is that we have the cultural and religious aspect, which, for example, multi-generational household are the other norm in South Asia. As you can see, and the study that the Open Safely did, the community in this is, I think that they did this in Western countries even, but people that comes from India, Pakistan, and Bangladesh, the majority live in households that consist of 3 to 6 and even more people. And in COVID times, we can really imagine like being in a house with 7 or 8 people. And I would even say that social distancing would be a very privilege, wouldn't it, if you're stuck in a house with a lot of people? And in addition to that, caring for those in need is not seen as a privilege. So people that experience negative experience from giving care to either your spouse, your parents, your in-laws, they experience shame. And this is a trend we see around Asia, as in like taking care of your parents is something that we have to do without question, that it is a privilege, it is a tradition. And another layer that is very interesting with the South Asian populations is that the gender roles. So daughter-in-law provide most instrumental and emotional support and coordinates medical care, where finances are handled mainly by men. And this used to be a traditional thing that happens also in the Western countries, but I think it has um, subsides to a more equal society, where in Asia, especially in Southeast Asia, it's a very common trend. So this is the South Asian caregiver characteristic. This is the demographic. And if you remember the ones that Dr. Shin just presented, in the global survey, we have more women, but somehow, some way, in the South Asian caregivers, we actually have a quite equal proportion. So we have 42%, sorry, I think it's a typo, 42% male and 58% female. So female is still a bigger proportion, but we have quite equal 42 to 58. And you can also see that we're dealing with the different demographic. Where in the global survey, people are mostly the people that are caregiving. They're doing caregivers are mostly in their middle age. Where in South Asia, it's the young adults and adults. So in the range from 18 years old to 39 years old. Majority have 1 to 3 children, and there are 44.6% are single and 47.1 are married. And then majority, almost 50% of our data comes from Pakistan, while 24.1 come from India and 24.9 come from Bangladesh. The other category, the 5.8, we describe it as people that either was born in South Asia and then they move or migrate to another country, or was born in another country and then they migrate to South Asia. And then the education level of our respondents are quite high. Actually, 56% have post-secondary, and then they self-reported that they have fairly well financial situation. Most are employed, and they reported good to very good mental health and physical health. And this is the caregiving characteristic. So majority, as we mentioned before about the multi-generational household, so 50% are giving care in their own home, so caregivers home. And then there's a smaller proportion of they're visiting the care recipient home or care facilities. And 61% experience severe COVID-19 effects on the caregiving, their the care activities, and they also experience loneliness some of the time during COVID, majority of them. But this is where it gets interesting. So 35.6% admitted that they never experienced caregiver burden, while 33.5% mentioned that they sometimes experience this. So this is our typical respondent, just to summarize. So majority are young adults, they're married when 1 to 3 children, they're employed with secondary education, with fairly well financed. They have good and they have good physical and mental health. They have never experienced caregiver burden. They experience severe effect of COVID-19 regarding the caregiving activities, and they experience loneliness some of the time during COVID. So after getting all of the demographics, we continue with our statistical analysis. Oh, sorry, this is also the characteristic of the care recipient. So majority are caregiving for the family, and majority actually in our population have physical conditions. So other than dementia, it's physical conditions for the South Asian care recipient, and the caregivers are taking care of adults most of the time. So we did an ordinal logistic regression to see the associated factors for the caregiving burdens. As you can see, being female, as usual, is very highly correlated with high level of burden. Being young adult and adult are moderately correlated. And this is the thing that I cannot really figure out, that being from Bangladesh is also very highly significant. Having no education and reporting poor finances are moderately correlated. And then having poor or fair physical health and poor mental health are also moderately correlated. And for the caregiving characteristic, giving care in the caregiver's own home is highly correlated. Well, loneliness experienced some of the time, and it's not. We also have often and never, and I use never as reference, but some of the people that experience loneliness some of the times, it's it's highly correlated with a high level of burden. And in addition to that, people that taking care of individuals with dementia and Alzheimer's are also correlated with high level of burden. So you can see from the quantitative data that some of our results is coherent with the global click survey, but there's also another layer and another explanation what we need to figure out on why the cultural and religious and even gender roles affect all of our results. So, but in another side of our survey in our study, we also want to mention that at the end of the day, caregiving burden, social isolation, and loneliness is actually a very personal and a very subjective experience. And we also have a qualitative sections that supplement to that. So, for example, this is one of our questions: how do you feel about your caregiving roles? And I figure out that we find a lot of answers that saying caregivers is noble work. It gives me pleasure to do that. It is my responsibility. It is something that I have to do, and I have to be happy, and I have to enjoy it. And for example, in the second code would be like, I like to care for people. I like to stand beside vulnerable people. I tried my best, and this person is my family member. So we also observe a little bit of stoicism, which people experience. This is the way it is, and we have to accept it. And the last one, what does loneliness means to you? If you're reading very, very closely around the codes that we have here, there's a lot of different perspectives on loneliness. Someone will mention, oh, it is solitude. Someone will say, oh, loneliness doesn't seem special to me. It feels lonely when you're short of money. So that's connected to your financial stability. And so someone said, when living with a family, if you do not get help from any family member, that is loneliness. So there's also querying with what Dr. Yao mentioned, as in like, you can be in a situation where you are with people, or you do connect with people, but you still feel lonely. So this is what we're doing in the South Asian, the caregiver click. So I'm going to give it back to Ira.
Super. Thanks very much, Anna. So I think that gives a bit of a flavor of some of the challenges and fascinations of doing something like a global survey, which is possible because of the technology that we have, and also the fascination because this was an event that has impacted everybody. There wasn't a corner of the world that wasn't affected. And so we're given this vast picture of how people have experienced things. And what's fascinating is that there's so many commonalities of experience, but at the same time, incredibly important differences. And I think the next steps for us will be to tease those apart even more, to understand regional differences and also differences within regions. Like, for example, as Anna mentioned, what's going on in Bangladesh? Why are they popping up as an important factor? So that maybe someone in the audience can have a comment about that, but we'll leave that for the minute. So I just want to finish with a final slide. Is very important. And the whole point of doing this kind of work is to change the world, to really inform policy, to give us data so that we can drive through change when we see there's a problem. And we all know, and the data support the fact that there's been a problem during the lockdowns. So this is where we start to put together policy recommendations. And this comes from a report that we wrote specifically for the Irish data in conjunction with a charity partner called Family Carers Ireland, as well as Alzheimer's Society Ireland. And so some of these may not apply outside of Ireland, but you can see how we've tried to take our findings and translate them into something that's meaningful to be taken forward for the charities to be able to lobby government. So first of all, we need to implement interventions specifically to address loneliness and social isolation because of the circumstances caused by COVID-19. If we go into this again, and it actually should be when we go into this again, because if some of you have been watching the European news, you will see that, for example, Austria, the Netherlands, Belgium, and Germany are now going into the next lockdowns. In Ireland, we're on the cusp of this ourselves, that we know how to do it better, that we learn the lessons, particularly in relation to people who are caring for people with long-term conditions in the same home, cohabitating with them. That we think about introducing a statutory home support scheme. And that's incredibly important and a huge step from where we are now. That there's legislation to give caregivers the right to respite and addressing caregivers' access to financial support, because we see the impacts of these things on the caregivers' outcomes. So I'm going to leave it there. And I think we're on time. So we might have a few questions. I'll pass it over to Dr. Saima, who can lead us in the next stage. So thank you very much for your attention. We really appreciate it. We hope you found it interesting.
Thank you very much. So do we have any questions from the participants? I don't have any question in the chat yet.
Good, that means it was all wonderfully clear.
Yes, maybe, or they might be asking on the Facebook, maybe. So I think I'll just wrap up. I'm grateful to the guest speakers and honored to have them with us. And this session was really informative, and I'm sure that people have benefited from it. I thank Dr. Anjum Taira, Director of DFDI and a faculty member of the Persian Department, who invited me to organize and host this international webinar on behalf of DFDI. And I would also like to say thank you to the media team for their technological assistance. Thank you to everyone who attended. I hope you enjoyed this webinar. Take care, and I think we have two messages. Yes, they are just great talks, informative. Thank you very much. So take care. Bye-bye. Bye.